was built to last. When the webs are weaving, I could change the past. With all my change.
Hello everybody, welcome back to another video on the channel. We are here today. We're going to go over some very high yield questions based on the educational objectives for the internal medicine board exam, and we're going to create our own AI driven and generated questions and then go through the answers that are analyzed with ChatGPT 4.0 version. Future episodes, we're going to also use other AI engines to create these questions and go through the options, and we'll compare and contrast. So we're going to see which one is best. But for the first few episodes, I'd like to continue with ChatGPT, and then we're going to add in things like Claude 3.7, DeepSeek, and we're going to use all these different engines and find our best way. But this is the best way to study, because you get to create as many questions as you want to, as long as you have medical concepts that you know are going to be untested and high yield on the boards. So if you're gonna basically stay with me until the end of the video, please drop a comment, please subscribe, and join the Patreon channel to access the notes that are downloadable. And let's get to the questions. All right, so the first one, and we have a 52-year-old man. He presents with progressive low extremity edema, foamy urine, and a mild fatigue. The physical exam reveals anasarca. Laboratory studies show hypoalbuminemia with a serum albumin of 2.1, and then a proteinuria greater than 4.5 gram per day. Serologic testing for ANA, Hep B, Hep C is negative. Additional workup reveals positive anti-PLA-R2 or antiphospholipase A2 receptor antibodies that are positive. Which of the following is the most appropriate next step in the management? So go ahead and pause the video right here, and then we're going to go through the options together. All right, so this is a question about membranous nephropathy. So this is a common cause of nephrotic syndrome. As you know, the patient presents with nephrotic syndrome. They have hyperalbuminemia. They probably have hypertriglyceridemia. They are probably at high risk of developing DVTs because of the high thrombin, antithrombin that is being released into the urine and filtered. Now, this membranous nephropathy pathophysiology is characterized by immune complex deposition in the glomerular basement membrane. Primary membranous nephropathy is caused by the anti-PLA-R2 antibodies, which target podocytes, and they lead to glomerular damage and the proteinuria. And these are very specific antibodies. The key on point is, if you are able to diagnose primary MN using the anti-PLA-R2 antibodies, which means if they will come back positive, you do not necessarily need a biopsy to initiate treatment. So nephrotic syndrome, so you got edema, foam urine, hypoalbuminemia, proteinuria here. You have the positive PLA-R2, and there's no evidence of a secondary MN. That's why they told you that the ANA was negative, the hepatitis studies were negative, so they didn't want you to go and do other things or think about the biopsy to try to eliminate every other cause or secondary causes of MN. So beginning corticosteroid cyclophosphamide, this is not the first line, unless there's severe renal impairment and rapid progression. Then you start them on this. Ordering a kidney biopsy would be unnecessary in a confirmed primary MN with normal kidney function. So another thing is, again, this patient does have normal kidney function, and they did, I think, tell you the only thing the lab was showing was hypoalbuminemia and proteinuria, and everything else basically is normal. So this patient did not tell us, the question did not tell us about a kidney function that's abnormal, or the patient developing a kidney disease rapidly, or any alarm symptoms that would need you to basically do a biopsy. So starting rituximab therapy, this is reserved for high risk cases with, again, progressive disease. And then referring for an urgent hemodialysis, that is not, again, a case when there is no acute kidney injury. And so the algorithm. So you have confirmatory testing for primary MN. This is the PLAR2 antibodies. If you have these positive, you do not need a biopsy. And the risk stratification is when you have a low risk, mild proteinuria, stable renal function, you can just continue with the conservative therapy with ACE-I and ARBs. If you have a patient with high risk, a lot of protein, worsening kidney function rapidly, then we need to consider immunosuppressive therapy and even a biopsy. So monitor for spontaneous remission, which can occur in about 30% of the cases. Primary MN, no biopsy needed. If you confirm it with a PLAR2, nephrotic syndrome with normal kidney function, start the ACE inhibitors right away. And if they are rapidly progressive, then consider immunosuppressants such as steroids, rituximab, and as such, reviewing the latest American guidelines, so the KDIGO or KDIGO guidelines recommend ACE inhibitors or ARBs for first-line therapy for low-risk primary membranous nephropathy. Biopsy is only needed if clinical suspicion for secondary MN or worsening renal function. Immunosuppressive therapy, including rituximab or steroids plus cyclophosphamide, is reserved for patients at high risk for progression. All right. So that's the first question. I think we did well here. I think it's a lot of information, but the most important high yield takeaway was the primary MN with PLAR2. All right. So let's go ahead and go to the next question. All right. So we have a 60-year-old man. He has history of metastatic lung cancer. He presents with confusion, nausea, and constipation. The labs reveal a serum calcium of 14.2 and a serum creatinine of 1.8. ECG shows a shortened QT interval. Which of the following is the most appropriate initial management? So we're going to pause the video right here and pick your answer. All right, so this is a question about management of hypercalcemia of malignancy, right? So the answer in this case would be calcitonin and intravenous normal saline. So let's go over the options. So you have a patient with severe hypercalcemia. Remember, anything greater than 13, that's the magic number, is basically considered severe hypercalcemia, and is most often, it's caused by malignancy. Lung cancers can do it, multiple myeloma, remember the crab symptoms, and the breast cancer can also cause it. The mechanism is related, in lung cancer especially, is related to PTHrP, increasing the serum calcium released from bones and reducing the renal calcium excretion. The clinical signs of hypercalcemia are confusion, nausea, constipation, polyuria, dehydration. You can have shortened QT interval and possible arrhythmias. And you can remember that mnemonic from USMLE, I think was stones, bones, Crohn's, psychiatric overtones, and things like that. And then you can also see the question dissection with answer element. So the key clues, again, was the severe hypercalcemia, most likely related to malignancy, the symptoms present, and the kidney function that is 1.8. So you don't want to really use any nephrotoxic drugs in that case. But also, cynic acid is not for malignancy-related hypercalcemia. It's usually for secondary hyperparathyroidism, remember CKD, or primary hyperparathyroidism. The Denosumab is reserved for the patients who use the bisphosphonate, but they're resistant, and so they're not the first-line treatment. And then the furosemide, we usually try to avoid nowadays because we don't want to worsen the volume depletion. So we try to avoid that as a first line. And zoledronic acid would be the second line, but is needed, it takes about 2 to 4 days to work. So you may initiate it if, your initial, normal saline and calcitonin are not really working. So IV normal saline restores the volume, promotes renal calcium excretion. The calcitonin will be able to rapidly lower the calcium by inhibiting the bone resorption, and it will take about 4 to 6 hours. Also, calcitonin, the intranasal specifically, can help with bone pains if somebody has, bone lesions. The second line, you have the long-term management, so you can do the bisphosphonates, which are zoledronic acid and the pamidronate. They take about 2 to 4 days, but then they can provide a sustained calcium-lowering function. And then the denosumab is for refractory cases or people with a really severe renal dysfunction that cannot get the zoledronic acid. So just remember, you have a severe hypercalcemia, malignancy, IV fluids and calcitonin first. they think about bisphosphonates second, and then avoid the furosemides or Lasix in these, unless the patient has a volume overload state that they can help with, and you want to do, volume management. This the guidelines kind of repeat that. They do say that loop direct only, basically repeating the pattern recognition, so nothing new in the guidelines there. So I think it was a very high yield question. They try to question, use a lot of things in this question. They could be change it and create another question. Like, let's say if you had renal dysfunction, then your severe renal dysfunction, your answer would be different. Or they could tell you, hey, this patient already got normal saline and calcitonin, and basically the calcium is still elevated. What are you going to do next? And then each of the steps could be changed a little bit, and then you have a new question. But once you do these questions and go through the options and do the pattern recognition, you can see and go through how I let AI analyze. It will basically cover all sorts of things that can come out of it. But you can always access the notes from my Patreon, and then you can use the summary of the notes and have your own GPT or AI create more questions for you. All right, so let's go to the next question. So we got a 64-year-old man. Yeah, he has CKD stage 4. He presents for follow-up, just a routine. His EGFR is 22, and he has no signs of uremia, hyperkalemia, or volume overload. He's currently managed with optimal blood pressure and proteinuria control, which probably ASI. Which of the following is the most appropriate next step? So go ahead and pause the video right here, pick your answer, and we're going to go through each of the options together. All right, so the correct answer here was the you want to get the AV fistula placed right away now, not because the patient has any urgent, but just because the AV fistulas will take some time to mature. So let's go through the question. So we got a CKD progression. When you're understanding that CKD progression could be unpredictable, patients with EGFRs less than 25 should be referred for vascular access planning to avoid any need for an emergency catheter, which would be high risk. You could get infections and things like that. So an AV fistula is preferred for long-term process for hemodialysis because it reduces the infection risk, improves long-term patency. AVF maturation takes about 6 months, so early referral is critical. So when you go through the question, so EGFR of 22, approaching the dialysis stage, so we need to, but there's no uremic symptoms, there's no hyperkalemia, there's no volume overload, those AEIOU that would indicate the urgent dialysis are not here. So we could plan, right? We want to avoid any emergent procedures. So here, initiating emergent, that would be wrong. Placed a tunnel dialysis catheter, again reserved for urgent dialysis. Scheduling for a peritoneal dialysis initiation, it is not immediate dialysis requirement, and the modality of choice should be based on patient preference. And then the monitoring the renal function until EGFR of less than 10, that would be delayed, because then you would at that point you probably need to place an emergent tunnel dialysis catheter and do emergent dialysis, which is not preferable. So when you look at the algorithm, so if somebody has EGFR of less than 25, just refer them for the AV fistula. Once they get to 10 and 15 and they have symptomatic uremia, then you need to be ready to initiate the dialysis. Urgent dialysis indications are the AIOU, hyperkalemia, the volume overload, metabolic acidosis, or severe uremia. Those are there. Now, this is kind of the pattern recognition, understanding what you're looking for. You're looking for, in all of that fluff of that question, you're looking for this number, the EGFR, you're looking for uremic symptoms that are there or not, and avoiding, and trying to avoid any immediate procedures if you can, and really plan out this process for the patient. When we go to the guidelines, the American guidelines, the KDIGO guidelines, they do also recommend the same. And then the peritoneal dialysis or hemodialysis planning should begin early to ensure patient readiness and prevent emergency access placement. All right, so this is it for this video. I hope you guys enjoyed the video. If you made it all the way to this end, please like, comment, subscribe if you want, and also join my Patreon channel to access the notes to create more of your own questions. We're going to be basically revolutionizing the way we are studying, because basically once you have the when you know what you're going to be tested on, you are able to use AI to create your own questions, which is pretty good. So I'll see you on the next video, and we're going to continue our GPT episodes. All right, have a good one.